All right. So I just start off by describing the problem. So osteoporotic vertebral compression fractures present to us in one of several ways. It may present to us with back pain, neurological deficits, which are rare, deformity, especially as a cumulative effect with several of them. But what makes them very special and often difficult to treat is that you might be dealing with an incidental fracture. About 30% of these are symptomatic, with the vast majority of them being asymptomatic. So the proposed solution is vertebroplasty or vertebral augmentation. And in these procedures offer pain relief by one of multiple mechanisms. It could be either microfragment stabilization, the exothermic reaction from the cement might ablate the intraosseous nerve endings and decrease pain sensation, and also might restore normal forces and strains on adjacent levels. The middle one was particularly interesting for me, so I just went into the literature that's trying to explain that. And these are studies that were cited by articles mentioning that mechanism. It turns out that if you actually read them, you would find that, for example, this study here shows that the typical cutoffs described as causing thermal injury are not met by the two cements used. And this study that came out 10 years later in 2009 used 11 different formulations, and none of which reached the thresholds. So much for that. And regardless of these small controversies, vertebroplasty offers an excellent bridge between best medical management and operative stabilization, faster return to ambulation, faster pain relief, and avoids the risk of surgery. So what does the literature say? So I start off by looking at filtered evidence. So the Cochrane review published about 5 years ago essentially says that they have found high to moderate quality evidence that vertebroplasty has no important benefit on pain, disability, or quality of life. So what literature says this? It's the famous two studies from the New England Journal of Medicine that came out together in 2009. And if you look at the graphs on the right, it doesn't really matter which one's vertebroplasty, which one's control. In fact, if anything, the one outcome where they diverge is in opioid use by patients, and that's actually been higher in the vertebroplasty group, this study. Insignificantly, though. The other 2009 article also showed the same. There are a few reasons why this is, and that's the reason for the presentation today. Also, very similar outcomes in the two groups, vertebroplasty versus placebo. So after this Cochrane review that came out and said there's no effect, after these two large studies that came out in the New England Journal of Medicine, why is this still controversial? So I just followed the PICO format. What patient was selected, what intervention was the intervention optimal, what's the comparator, and what was the outcome. So regarding patient selection, as I said, fracture is not just a fracture, it could be asymptomatic, but also you need to discriminate between whether this is acute or chronic, how did they attribute the symptoms to that fracture, and you also have to understand that this presentation, these trials mainly apply for osteoporotic compression fractures and not those related to trauma or tumor. So going back to the acute versus chronic, the two New England Journal of Medicine studies were basically on chronic fractures. They recruited patients up to a year from the presentation. So this is a more recent study, came out in 2016. It's the VAPOR trial, often cited in the Lancet. They basically looked at patients within 6 weeks of their fracture, and a good proportion of patients were treated within 3 weeks. And this study came out positive with significant improvement in pain outcomes. A secondary analysis subclassified those to within 3 weeks versus those 3 to 6 weeks, and the within 3 weeks performed much better. Also, following the theme of needing to actually read the studies, the Vertos 4 trial, which was which was titled as Evaluation of Painful Acute Osteoporotic Fractures. If you read the paper, they've recruited patients up to 42 days median in the treatment arm, which is essentially 6 weeks. Which is why when they went ahead and performed subsequent analyses, they changed the title from acute to, between parentheses, subacute. Now, this is the one that prompted me to title this presentation the way I did. I accepted the invitation, thank you, committee, when this study came out. And it was interesting because it showed up on social media as the end-all trial for chronic osteoporotic fractures. But if you look at the title slide, which was on the webpage, these two graphs do not look impressive, but it says here is at 12 months, greater pain reduction and improved health-related quality of life in the vertebroplasty group versus active control. And the editorial associated said that this is a critical addition to the literature, shows significant improvements in pain and quality of life. But when you go to the limitations, buried as number 3 in the last paragraph, it says, though statistically significant, the difference between the vertebroplasty and active control group in reduced pain was slightly smaller than the predefined threshold of clinical significance. So I interpreted that as not meeting primary outcome. I might be wrong. So that's the P in PICO. What about the I? Turns out that this procedure is very technically nuanced. We should ask ourselves, have we restored vertebral height? Do we need to use any do we need to augment technology like a balloon or an expandable device? What kind of cement do we use? How do we deliver the cement? And also importantly, how much cement did we actually put into the vertebra? So essentially, is every vertebroplasty the same as the other? And this is also very controversial. I'll just save you the reading. There is no good answer. And this is also another example following the theme of actually having to review the evidence. Here they say in the conclusion of the study that came out, I think last month or this month, that the spine jack showed a safe, effective adjunct and greater improvement in vertebral body height restoration and kyphotic angle. If you look at the difference, it's a 2-degree difference between it and vertebroplasty. So I don't know if 2 degrees is significant, but then again, I'm still learning. If you go through the meta-analyses, also you will find that it is very heterogeneous. The procedure is not standardized. Robotic versus non-robotic, vertebroplasty versus kyphoplasty, high viscosity cement versus low viscosity cement, also unclear. So the best way to evaluate this in a controlled setting would be cadaveric studies or finite element models. And it's useful because you ask yourself, so is the vertebroplasty in A similar to the one that's lower in the picture? And on the right, you can understand that the second vertebra, the procedure was aborted because the vein was filling. So in essence, not all vertebroplasties are alike, but also these pictures show that it's very difficult to pinpoint the exact source of pain. This was a neat study that looked at the effect of gradually increasing cement volumes on the biomechanics of a fracture model. And what was neat about this is that it showed me what 13% fill looks like and what 25% fill looks like. So that's what's in the images there. I would have said that the top picture was 50%, that the bottom picture was 100%. Turns out that that is not the case. And also, they reached 13% with 3.5 cc's of fill, and they reached 25% with 7 cc's of fill. If you go back to the original 2 studies that came out negative in the New England Journal of Medicine, the average injected volume was 2.1 or 2.8 cc's. So that just tells you that those were possibly suboptimal procedures. There are people that talk about how kyphoplasty restores sagittal balance, and that's associated with improved outcomes. Again, this is just to remind people that we're talking about 2 degrees difference here. But also, when looking at clinical studies, they found that performing balloon kyphoplasty does not significantly affect global sagittal alignment. All right, so that's the end of I, and we're halfway through. What about the comparator? So that's also complicated. The 2 New England Journal of Medicine trials were actually against active sham, which is what I'll go through. So was the Vertos 5. So the active sham was essentially local anesthetic injection in the area of the pedicle or facet. And if you look at the performance of a facet injection with local anesthetic, it is actually rather helpful in the compression fracture patient. In this study, a third of patients technically suitable for vertebroplasty responded beneficially to facet joint injection. So this tells you that you are actually comparing two treatments, which might explain why they're negative. And also, if the outcomes were negative, this might be a point for doing facet injections in this population. One of the fathers of pain medicine, Nikolai Bogduk, conducted this study on patients. The biomechanical model here is axiomatic, which I think just means theoretical. So he shows here that the compression fracture, if it's kyphotic, would result in stretching of the facet joint, while if it's just a burst, or if the end plates are parallel, then it might cause pain through compression on the facet joint and excess loading. He showed in 6 patients that just doing facet joint injections or interventions can result in dramatic improvements in pain. So that means that you should interpret these trials possibly not against sham, but against another treatment, which may be relevant in daily clinical practice. So how about the outcome? Well, that is also difficult. As we've seen in the VAPOR 5 trial, what is statistically significant, if you're following clinical significance, might not be the same. This was a nice paper that came out of a spine group where they looked at the minimum clinically important difference and how it's derived. So it turns out that these are very complex statistical exercises, and depending on the method you use, you will get very different results. So it says here the minimum detectable change appears statistically. So potential MCID calculations yielded the range of values: 5-fold for ODI, PCA, physical component score, and leg pain, 10-fold for back pain. So even what sounds objective might in fact be subjective, because you have to decide which method to use. So in conclusion, vertebral augmentation definitely has a place in patient care. It is helpful in the management of osteoporotic vertebral compression fracture, but what remains is how to select the optimal candidate for this procedure. What we seem to know now is that acute responds better than chronic. Better cement fill appears to be beneficial. And sagittal alignment and vertebral height restoration warrants further study, but that's because of the discrepancy between just calculating a simple kyphotic angle versus global spinal alignment, which is what we as spine surgeons are used to think about. Guidelines are desperately needed for both the selection and technical procedural targets, and prospective registries would be beneficial to understand how these perform in the real world. Thank you.